Cataract is the most common cause of vision loss in people over the age of 40 and one of the principal causes of blindness worldwide. References to the treatment of the condition date back over 3,000 years, and yet it is only in the modern age that advances in science, technology and commerce have enabled medical practitioners to take groundbreaking steps forward in the treatment of the disease. As surgical techniques, measurement systems and medical devices evolved, one particular device stands at the centre of attention: the IOL. For over 30 years, Medicontur has specialised in the development and manufacture of high-precision IOL systems for the treatment of cataracts and other ocular diseases. As the patient's quality of vision lies at the heart of the Medicontur philosophy, a strong commitment to innovation and development has enabled the company to become a world leader in the ophthalmic field. With a meticulous focus on material, design and optics, Medicontur has developed a unique IOL portfolio which provides doctors with wide-ranging options and the ability to select the most suitable IOL for their patients. Thanks to a global network of professional partners, patients around the world have the chance to enjoy their visual freedom once again.
Good afternoon, welcome to the Medicontur Symposium on the meeting, the European Society of Cataract and Refractive Surgery. You are going to see an incredible panel of speakers. Thank you very much for being here with us, for your effort in the synthesis of your presentation. We are going to have a very short presentation. We would like to cover all the issue about the multifocality. No more than 5 minutes. We have both a cocodrilo, if you last a little more. And if we could begin to show the first presentation, talking about the understanding dysphotopsia. It's the number one of Joaquín Fernández, it's not that. Well, we would like to show you all that we know about dysphotopsia and how it's the Liberty technology addresses it. This is our declaration of interest. We are a consultant of Medicontur. And talking about the discomfort related to the light, we have in one side the professional perspective, talking about the different situation of photometric phenomena, glare, halo flare, starburst flash, and streak, exactly that you can see. But in the patient perspective, the most important situation is not as the characteristic of the photic phenomenon, but is they are bothering the patient or not bothering the patient. We published recently this review about what we know about these 30 years living with positive dysphotopsia after intraocular lens implantation, and we're going to show a little ideas about that. What could be the advantage of having only 7 rings for a trifocal lens? It's very important to know that when we are our patient and seeing for distance, the halo represent the defocus of the near focus. So what could depend in the amount of the dysphotopsia? These 3 parameters, this is the most important probably slide. The aperture, the addiction of the lens, and the area destined to near vision. The more is the aperture of the pupil, the more is going to be the dysphotopsia, the more is the addition, the more is to be the dysphotopsia, and the more is the area destined to near vision, the more is going to be the dysphotopsia, and inverse, the less ring, we are going to have less dysphotopsia. We have this simulation in the themax. You can see at the top of the left, almost we don't have any disturb of photic phenomenon. In the front, you can compare with another trifocality. This is more or less the idea. We are collecting this data. It's very interesting that in this allometer, you have on the right hand quite similar light distortion index, not too big, but we have a great dispersion of sensation of patient. Not at all bothersome, slightly moderating, and very bothersome. So probably we need to select patient that in the preoperatory, this data of the preoperatory, we would like to exclude patient that without any cause, they have complained about very bothersome of dysphotopsia. And what could be the line, the cutoff of pass to a slightly to moderate sensation of dysphotopsia? Around this index of 15%. This is the idea I would like to take in your mind. So this would be the cutoff between the slightly dysphotopsia to moderate dysphotopsia. Well, we have not published in our group comparing the Liberty EPS 1.0 in 3 months with the EPS 2.0. And you can see here with the new EPS 2.0, the index, the light distortion index, is around in the 2.0 of 14.16. It's a very interesting concept that is not only to improve the intermediate, but also is going to reduce in a big scale the sensation of dysphotopsia. So Liberty technology decided to fit responsibility to patient needs according to his pupil and the daily task. And this 7 Rita we saw, and the EPS technology reduced the light distortion to almost common preoperative level. If our patients have a little amount of cataract, we are going to develop more research in this concept. Probably the next year we could tell you what could be the cutoff of operating. But more or less talking about the OSI, the cutoff of the OSI in terms of the equipment, the OCAS, the HD analyzer, probably could be around 25. So this is the first presentation, and I would like to present to Dr. Zoltán Nagy. He's going to explain us the importance of correcting corneal astigmatism when implanted presbyopia-correcting IOLs. Thank you very much.
Yes, I would like to tell you the interim analysis after the implantation of Liberty 677 MTI intraocular multifocal lens. I cannot proceed. Okay, so astigmatism correction during cataract surgery is crucial in order to achieve the best possible visual outcomes. According to several studies, 87% of the cataract surgery patient has preoperative astigmatism. 41% of them, the corneal astigmatism is larger than 0.75 diopter. In another study, 55% had larger corneal astigmatism than 55%. So it is very important for a successful IOL implantation because only 0.25 defocus decrease the modulation transfer function significantly. The total corneal astigmatism, and do not forget about the posterior cornea, and also we need a precise calculation, and new regression formulas like Barrett and Guadalupe should be used also. There's an in vitro simulation that shows the potential source of patient's unsatisfaction when astigmatism was not corrected properly. Here is the monofocal case, diffractive multifocal case for far focus, and here is the diffractive multifocal with intermediate focus, which is even worse than in the far focus. So patient satisfaction referred in the literature based on residual astigmatism value, you can see that over plus 0.75 diopter patients are not satisfied, and if it's over 1.25 diopter, that no of the patients were satisfied at all, regardless what kind of multifocal toric lenses have been used during surgery. The purpose of our current investigation was to assess the clinical performance and rotational stability of the Liberty 677 MTI multifocal toric IOLs. The study included 60 eyes. Corneal astigmatism was between 1 and 6 diopter. The follow-up, we introduced the first 14 patients after 3 months follow-up time. This is a biflex platform, proven high rotational stability in another clinical studies. Here you see previous corneal studies. And regarding the efficient refractive correction, 83% of the cases were within plus minus 0.5 diopter, and 100% of the cases were within plus minus 1 diopter regarding the spherical equivalent refraction. Regarding the refractive cylinder, 72% were within 0.5 diopter, and 94% were plus minus 1 diopter of the cases. The cumulative visual acuity. These lenses provided excellent vision at all three distances. Here is the distance, the intermediate, and the near vision. We assessed the uncorrected and also the best corrected visual acuity. This is the visual acuity defocus curves. Outstanding trifocal performance have been achieved in monocular. This is the left eye, and this is the right eye. And when we assess the binocular function, also with the two eyes together. Contrast sensitive defocus curve also showed similarly very good and very high quality of results. Patients were also asked to verify with the VFQ-25 questionnaire regarding the satisfaction, and the maximum point was 100. Here is the highest rating, and the average sum was 93.39, so it's a very high result. In conclusions, based on our currently available clinical data, the implantation of trifocal toric liberty multifocal IOL is safe, is efficient in correcting refractive errors, including astigmatism. The IOL provides excellent visual acuity and contrast sensitivity at all three examined distances. Patients report on high satisfaction. The multifocal lens analyzer iPad application by Q-Vision Spain is an easy-to-use and quick approach to assess visual acuity and contrast sensitivity. There need more accurate and established conclusion. This will be feasible to be drawn after all our patients have completed the 1-year follow-up. However, the initial results are very promising. Thank you very much for your attention.
Thank you very much, Dr. Nagy. And now, Dr. Guadalupe Cervantes is going to tell us what could be the influence of the angle kappa and the high order aberration when we implant trifocal lenses. Thank you very much, Guadalupe.
Thank you, Joaquín. Good afternoon to everybody. I'm going to talk about the influence of the angle kappa and the high order aberrations in the visual quality of trifocal patients. I don't have any financial interest. Some of the challenges that we have as doctors when we are going to implant trifocal lenses are the most presbyopia lenses have multiple concentric rings, that's one. The second one is that after surgery, these patients can have some tilt and decentration, and of course, if we have a functional deviation between the visual and the pupillary axis, we are going to have troubles. And these are some of the impacts that we have in the patients if anything of this happens. High order aberrations, decreased visual quality, dysphotopsia, and of course the negative impact of the optical performance. The most frequently measured parameters, some of them, or the most important ones now, is the angle kappa. And we have to remember the angle kappa is formed with the intersection between two lines, the visual and the pupillary axis, and these are the measures in hemetropic, myopic, and hyperopic patients. We have to remember that angle kappa, as you can see in the red line, is called also the mu chord, and is between visual and pupillary axis. There is a problem with angle kappa that is a pupillary dependent, so we will have lots of problems when we talk about angle kappa because the great variability that we can have in the patient, so that can cause lots of problems. After that, we have to demystify the angle kappa, and now I'm going to talk about angle alpha, that is the most important factor now that we have to take in consideration. Angle alpha is formed by the intersection of two lines, is the visual and the optical axis. This is not going to be modified, it's much more stable. Why? Because it's pupillary independent. And we have to remember that 55% of our population they have a large angle kappa, and of course the hyperopic patients are the ones who are going to have also an alpha angle larger than the rest of the population. Not that we have been recognized their importance, but there is little data regarding what's the impact of this angle alpha in the visual quality of the postoperative patients. So we decided to do this study that just recently came out. We performed this in Mexico in the Association to Prevent Blindness, and we wanted to measure the influence of angle alpha in the high order aberrations in two different trifocal lenses. And these are some of our results. There was no association between angle kappa and the postoperative visual acuity, neither in the panoptics or the atelesa trifocality. And then we found that the internal aberration show an inverse correlation with the sphere radio. We have to be very careful because sometimes patients who have angle alpha larger, they can have also problems with the centration of the lenses, and this is going to present dysphotopsias, also diminished visual performance once they have it implanted in the eye. So after this study, I just finished a prospective study. I did it in 28 presbyopic patients, and we did 56 implants binocularly, and our goal was to leave glasses independent to all the patients. After we did this, one of the possible correlations we performed, we measured angle kappa and angle alpha pre and post-operatively, and we tried to correlate these two angles with the visual outcomes, with the high order aberrations, and also with the coma. One of our main questions was, is there any parameter change during or after cataract surgery? And this is the result we just had. The angle kappa decreased significantly, as it has been reported by Kranitz et al. Also, coma was decreased, and the high order aberrations also were decreased. The only thing that was maintained was the angle alpha in all our patients. So when we did the linear regression and the correlation analysis, these are some of the results that we can show you. First of all, there was a postoperative angle kappa correlation in photopic conditions with intermediate and near visual acuity, and possible, just in some cases, with a distant visual acuity and with the high order aberrations internally in the cornea. There was no correlation between high order aberrations and coma with the angle kappa. And in terms of angle alpha, there may be a correlation with the postoperative total corneal aberrations, but does not predict, this is a very important point, does not predict the future visual outcomes. And lately, the alpha angle in photopic conditions seems to correlate with corneal and internal high order aberrations, intermediate and near visual acuity, and in some patients just with a short or the near visual acuity. So some of the pills that I would like to give you to take home are these. Angle kappa is not a useful tool in selection of the implantation of a multifocal intraocular lens. So we have to forget a little bit about angle kappa. Now we have to think about angle alpha. Angle alpha has much more higher impact on visual acuity and also on the optical aberrations, and we need to do a further analysis and maybe to collect more cases so we can have a deeper understanding and interpretation of all this data. So thank you for all your attention.
Thank you very much, Guadalupe. You will have two of the most important articles about kappa and alpha. Congratulations for that. Talking about papers, we are going to have fun with Dr. József about one of the longest paper about a follow-up with a trifocal lens. We are going to see the 5-year outcomes in the long term of the Liberty trifocal. Thank you, József.
Thank you. Dear audience, I'm honored to be able to talk about my long-term experience with the Liberty lens. About 5 years ago, when I started to introduce the multifocal IOLs into my private practice, I was looking for convincing arguments as to which multifocal IOL performs to make my patients more satisfied. Multifocal IOLs are usually chosen by patients of active age and are not planned for short term. There were no long-term results on multifocal IOLs in the literature at that time, and just even recently I found 2 articles on longer-term follow-ups on multifocal IOLs. In 2013, we initiated a prospective study to examine the promising Liberty IOL that was new and not available in toric version at the time. The long-term study was planned on 100 eyes of 50 patients to follow up morphological and functional performance of the IOL in the eye. In addition to morphological data, functional visual acuity, defocus curve, contrast sensitivity, visual artifacts, spectral independence were examined, and patient satisfaction was measured by the VFQ-25 test in 1 month, 3 months, 6 months, 1 year, 2 year, and 5 year time points. Our 2-year follow-up results were published in the GCRS in 2019, and I'm fortunate enough to announce that the 5-year follow-up results are presented in the current October GCRS issue. Let's see the charts. At 1-year follow-up, we were able to evaluate 100 eyes, and 5 years, 74 eyes. The spherical equivalence in the 1st and the 5th year process felt predominantly in the range of minus 0.13 to plus 0.5 diopters, and only slightly modified towards plus diopters over the 5 years. Cylindrical deviations remained within a quarter diopter. All this data suggests a firm intraocular stability of the IOL. It is clear from the visual acuity outcomes that in all important focal lengths, the IOL performed very well, and this remained almost unchanged over the 5-year follow-up period. As Liberty is a multifocal IOL, it is worth paying attention to the white columna representing the uncorrected vision. We're plotting results of follow-up time points of the study. The line diagram reveals that there has been essentially no change in visual performance since 3 months, and the visual acuity maintained in all foci. Contrast sensitivity measurements reflected surprisingly good values at the end of the 1st year, similar to the monofocal IOLs, became slightly lower at the 2nd year, which were maintained by the end of the 5th year in all light conditions. The green lines, the lower ones, are representing the pre-F values, that's why they're so low. The PCO rate was low. No YAG capsulotomies were carried out until the end of the 1st year. Only 22% of the lenses needed YAG capsulotomy by the end of the 5th year. This is due to the feature that the Liberty IOL has a 360-degree, really sharp edge around the optic part. Well, subjective experience of visual artifacts was low and maintained from the 1st until the 5th year, as evidenced by the VFQ-25 test. Well, in summary, these data, like other Liberty study evidences, confirm the persistence of the early good results. My personal convincement is reflected in the fact that now Liberty IOL is the most preferred chosen lens for our patients that want to implant multifocal IOLs. So thank you for your attention.
Okay, thank you, József. Excellent explanation of your paper, your very interesting paper. We are going to pass to the EPS technology. What could be an incredible, amazing, very clever idea to achieve the trifocality in comparison with other platforms. The EPS presentation, please, of Joaquín Fernández. I'm going to open mine directly. Okay, that's right. What could be the interest of this technology? Because as we know, other platforms achieve the trifocality combined to pattern of diffraction. So we are going to need more rings, probably more dysphotopsia, more photic phenomena. What is exactly the EPS? Well, the title is pushing the limits in the achieving of the wavefront. Well, you see here, this is images of the optical lens, measurement provided by the Medicontur Research and Development Department. And the idea of the EPS is a change of phase, a rise of phase in the middle of the lens, in the first ring. So we are going to achieve the intermediate vision, modify the phase of this first ring. And we compare the EPS 1.0 to the 2.0, you can see exactly this increasing in the intermediate vision in the range of 1 to 2 dioptries with very small reduction to prevent the performance loss of the far and the near focusing. When we see the axial MTF and we compare a bifocal at the left, the restor, and the right, the trifocal, a grid of panoptic, we can see in the middle the new EPS of Liberty, this amount of MTF in the middle, but the most important is the reduction of the near and the distant is very quiet, it's very little. So it's very interesting, this conception. This MTF, this axial MTF is for 3 millimeters. We can see here the PSF maps with an ISO model and this frequency, and you can see this continued focus on the bottom of the new EPS in the middle, in the intermediate vision. Well, this is the prediction model that we create in the paper, as you can see there, when we apply to the EPS 2.0, and you can see here the MTF area under the curve for 3 millimeters of pupil diameter. And this is the idea, the prediction of the visual acuity that the model predict that could be in our patient. This increasing in the intermediate vision in the range from -1 to -2. And it's very interesting that when we measure exactly in clinic, this is the defocus curve when we compare the EPS 2.0 with the EPS 1.0. As you see, exactly quite the same. This is the prediction model, this is the clinical outcomes, exactly quite the same. You can see an improvement of the intermediate vision, and when we saw the contrast sensitivity focus curve, we have more or less the same amount of contrast sensitivity in the distant and the near vision, preventing this loss of far and near. Of course, in this CMAX simulation, we are going to have, of course, quite the same. We expected to have quite the same, but it was a surprise for us that when we measure with this allometer in the clinical measurement, when we measure the photic phenomena with the light distortion index, as we showed before, we discover in the EPS 2.0 this very low index of the photic phenomena, probably even less than in the 1.0, that is, it was good enough, but this reduction is very interesting, putting effort not only in the 7 ring, but putting effort in the intermediate vision is going to reduce this index of allo. So in conclusion, the new EPS 2.0 enhance the intermediate vision, maintaining the advantage of the EPS 1.0 as we saw, and this early clinical findings suggest a reduction in the photic phenomenon that we need to continue to investigate. Thank you very much for your attention, and now, thank you. Now we are going to see three spectacular presentation coming from 3 incredible speakers talking about why to implant the AddOn lens. First of all, the editor of the journal Cataract and Refractive Surgery, Professor Sathish Srinivasan, is going to tell us a brief introduction for that. If we could present, please. Can connect with Sathish.
Good afternoon, everybody. My name is Sathish Srinivasan. I'll be speaking to you about the AddOn IOLs from the Medicontur. These lenses are primarily designed to be implanted in the ciliary sulcus. And as you can see, these have got some unique design features. which helps these lenses to be implanted in the ciliary sulcus. First of all, these intraocular lenses have a 4-point haptic fixation, so that which increases the stability of these lenses when implanted in the ciliary sulcus. They have a non-dot design which gives excellent rotational stability. This comes in really handy if you are using a toric intraocular lens. And once again, the square design gives us a large optical surface and thereby preventing any iris cap. A few years ago, we conducted a human cadaver study where we took a human cadaver eyes which had undergone cataract surgery with different kinds of intraocular lenses within the capsule. And we used the Apple Miyake view and we removed the entire iris surface. And these are the Apple Miyake view showing the primary intraocular lens. In this example is a plate haptic lens within the capsule. And in this example is a 3-piece intraocular lens within the capsular bag. We used all these pseudophakic human cadaver eyes and we implanted the add-on lenses on the top of these primary lenses in the capsular bag to look at the stability of the add-on lenses, and we performed anterior segment OCT on sort of add-on lenses. So this is a 65-year-old female who was keen on refractive lens exchange. Her preoperative refraction is as shown above. She was slightly hyperopic with a small amount of corneal astigmatism. And that's her ocular biometry showing an axial length of 21.81 millimeters in the right eye and 22.72 millimeters in the left eye. And she underwent trifocal LISA, the Zeiss IOL trifocal intraocular lens implantation for both procedures uneventful, but unfortunately in the post-operative period, she developed an unexpected myopic shift in the right eye. Clinical examination showed that she had capsular bag distinction syndrome, once again illustrated in this diagram and confirmed by shine fluid tomography showing the cloudy fluid trapped between the posterior surface of the IOL and the capsular bag. Although she underwent a deangulated posterior capsulotomy to drain the fluid, unfortunately the IOL, which was pushed forward, did not fall back into the posterior capsule. Therefore, she ended up having this myopic shift. As you can see, the uncorrected distance visual acuity about 3 months post-operatively was 690 in the right eye, whereas it was pretty good at a 6/5 in the left eye. Binocularly, she was managing and she was obtaining a vision of 6/6. As at this point, we decided not to intervene but keep her under review. About 8 months later, she came back complaining that she couldn't cope with the right eye. Once again, the right eye unaided distance visual acuity was 624, and a manifest refraction showed a myopic error of -2.75 with a cylindrical correction of 1 diopters. So at this stage, we discussed about various surgical modalities available, and she decided to go on with the secondary piggyback intraocular lens option. So the online calculator was used as shown before, so the manifest refraction was entered. She also underwent the pseudophakic biometry in the right eye, so she entered the pseudophakic axial length, the pseudophakic anterior chamber depth, and the pseudophakic postoperative keratometry. Along with the manifest refraction, the online calculator was used, and the expected add-on IOL power was -2.75 with the 1 diopter cylinder to be implanted at 3 degrees. So, as planned, she underwent a piggyback toric IOL implantation with the AddOn. I'll show you the surgical procedure here. As you can see, it was a toric correction, so therefore we are marking the steep meridian at 100 degrees where my surgical incision is going to be, and the intended IOL for the toric. As you can see, the small opening in the posterior capsule for the laser capsulotomy to drain the fluid, which was unsuccessful. We have injected OVD into the anterior segment, and we used a 2.2 millimeter clear corneal incision, following which we are injecting more OVD to open up the space in the posterior chamber between the posterior surface of the iris and the anterior lens capsule, so that we create more room for implantation of these add-on toric IOL. Once again, OVD is injected to open up the space in the posterior chamber behind the iris, and through a 2.2 millimeter clear corneal incision, these lenses are atraumatically injected into the anterior segment. Once again, you can see these lenses very slowly and very nicely unfolds. You can see they're leading to haptics coming first, followed by the optic, and then the trailing to haptics. Once the lenses are injected, then these haptics are very easily tucked using either a Sinski or a Kugler device, and they are nicely tucked behind the iris into the posterior chamber. Once all the 4 haptics are tucked in, because it's a toric IOL, we are going to rotate these lenses so that the marks on the toric lenses correspond to the corneal marks, which we have done roughly, which is about at 58 or 60 degrees. Once the lens is placed, because of this 4-point haptic fixation, these lenses are extremely stable, and now we are going to use the bimanual irrigation aspiration system to not only remove the residual OVD from the anterior chamber, which will have a material. So the post-operative period was uneventful, and the patient recovered excellent unaided vision of 6/6 in the post-operative period, and she was quite happy that she was happy enough to send us a thank you note explaining her delight following this add-on lenses. On this note, I will end my talk. I hope you enjoy the rest of the Medicontur Symposium, and if you get a chance, please visit the Medicontur booth so that you can have a hands-on experience on these add-on lenses and enjoy the rest of the meeting. Thank you so much.
Thank you very much, Sathish. Now, one of my old friends, Dr. Mertens, is president of the IOLs, the American European Society of Surgery. He's going to tell us, Eric, thank you very much for coming, what could be the reason for him of the permanent option of this add-on to pseudophakic patients with dry eye. Thank you very much.
Thank you, Joaquín, for this introduction. So, what about dry eyes and the touch-up when you already implanted these eyes with an intraocular lens with a premium IOL? So, I'm a consultant for Medicontur. This is my financial disclosure. How can I forward this? Can someone help me from the technician? Because when I click it, just repeats the... Yes, thank you very much. So when you look at the literature, this is a paper published by Oliver Findel in the Journal of Cataract Surgery in 2015. You see that approximately 20% of patients, depending on their actual length, require refraction correction. And when you go to an actual length of 20.5 millimeters and lower, it goes up to 30% with a refraction of more than 1 diopter. So this is not good when performing, of course, premium IOL surgery. What are your possibilities? You can fit them with contact lenses or spectacles, but of course the patient did not come to you to end up with another pair of spectacles or contact lenses. You can of course exchange the IOL, which of course you can rupture the posterior capsule and all other stuff which is going on. You can do laser refractive surgery, PRK, LASIK or SMILE, and you can also use add-on lenses, which was already pointed out by Sathish in his presentation. Now for me, the first Q add-on lens is the first choice, and I use it in 2 particular cases, in ametropia after cataract surgery, and also when people were already fitted with a monofocal IOL and say, oh, I would have chosen the presbyopia-correcting IOL, but I hate reading glasses, please help me. So there are also add-on lenses which are available for the correction of near and intermediate. What are the characteristics? There's a nice safety record of the lens. More than 10,000 are already implanted worldwide. There is no IOL touch because of the convex-concave configuration of the lens. It's easy and safe surgery. The 2.2 millimeter incision was pointed out by Sathish as well. It has polished edges, so don't have to be afraid that the iris is going to be shaved. The intraocular pressure is no issue, and it is also reversible. Now, this is one of my cases. This was a WIOL, so this is a premium IOL with full range of focus correction. It is actually a hyperbolic design, but we ended up with an ametropia. So this is a very large lens. It's 9.5 millimeter diameter. To take this out is nearly impossible because of the dimensions. So we put in the add-on lens. And as you can see here, this is straightforward surgery. The lens loading is in any lens loading very important. You have to take great care that the lens is loaded properly. The haptics are very flexible, and you need to make sure that they are in the cartridge. It seems logical, but you have to take care of it. Also, injection very slow, and the haptics will unfold slowly into the sulcus. And then with the other hand, with another instrument, you can tuck these behind the iris. And afterwards you can just irrigate. Also behind the lens, I do with monocanicular irrigation aspiration. I go under the add-on lens, I get rid of the viscoelastic, and then I go above the lens. Here also, can you proceed to the next slide, please? So when we review the literature, this is a publication in Clinical Ophthalmology in 2017, was stated by Gunderson and his co-workers. In conclusion, he said the secondary IOL appears to be safe and a good surgical option to correct residual refractive error after the primary IOL implantation. So why not do laser? Why not do touch-up with LASIK, PRK with SMILE? So I used to perform LASIK on these cases. But we ended up with not completely satisfied patients. Why? These patients are 50, 55, 60 and older, and they tend to have, of course, more dry eye than our younger patients. So we looked into this, and also when reviewing the literature, this was published in 2017, how satisfied are patients after cataract surgery, and what are the driving forces behind it? And it is, of course, when you have a refractive error, they're not satisfied. But the second main reason was dry eye after surgery. So this is why we do not use laser, because 62% of my cases had severely abnormal non-invasive breakup time of less than 5 seconds. And when we asked for the satisfaction rate, it was only 73%. So that's why we changed to the lens-based approach. On another basis, when you do a corneal-based approach, it's irreversible. And of course, I talked about the dry eye. The lens-based approach is reversible, and you will not induce dry eye in these patients. So in conclusion, we need to inform about more options for surgical enhancements. Well, we need to talk about, of course, contact lenses, spectacles, but they do not come to you to end up with spectacles or contact lenses. We need to test all patients preoperatively on dry eyes. It's very easy to perform nowadays. With the machines around, you can take your breakup time very easily. You can look at the meibomian glands with imaging. And now, by doing this, by changing from corneal refractive surgery to the lens implant in the sulcus, our satisfaction rate went up to 93%. So consider also the aspect of reversibility in case further interventions are likely to be needed in these cases, and individualizing these patients the best suited enhancement option based on diagnostic results. I thank you very much for your kind attention.
Thank you very much, Eric. It's a pleasure. And now, my dear mentor, Dr. Filomena Ribeiro, is the Secretary of the ESCRS. He's going to tell us what could be a good option to think about the add-on lenses, talking about the residual astigmatism. Thank you very much, Filomena.
Thank you so much, Joaquín, for the invitation to be here. And because you are my friend, you let me the stream cases. Thank you so much. But the reality is this IOL is really an opportunity to treat celophakic eyes that we haven't before. So these supplementary sulcus IOL, they have all the abilities to add to a celophakic eye, but for extreme cases, we also need the fact that they are reversible. As you can see, it's very easy to explant this IOL. This IOL was explained because it was implanted on the reverse, and we could do it again. It was one of the first cases, but you can see how easy it is to explant this IOL. So this gives us opportunity to treat some other cases because there is no really contraindications for the implant of these IOLs if we respect normal anterior segment anatomy, if the IOL capsular bag is stable, and if we have a good anterior peripheral capsule. So we can do is treat residual refractive error, as we can see in the previous presentations, but also treat presbyopia. And we can do it in celophakic eyes already or in duet implantation. Also for post-LASIK cases, and in the dry eye in these cases is also an issue, and some extreme eyes. I will show you the extreme eye. This is a woman that was done cataract surgery like 3 years before. She was implanted with a monofocal IOL, and 6 months in post-op, she was very, very dissatisfied. She went to several consultations, different doctors, 2 years with this process, and she felt that she could see better. If we see the topographic and the OCT, we cannot blame the doctor who implants the monofocal IOL. It's true, it's extreme cases. Posterior keratoconus, we can agree that the monofocal solution will be the best. But the patient felt that before, with contact lenses, she could see better, and now with glasses, she had a poor quality vision. And if we see the pentacam analysis Fourier, you can see here that in the very center of the cornea, we can really define a very regular astigmatism. So we talk with the patient and explain everything about this issue, and we try to use an add-on IOL to treat this astigmatism. And we have done that. You saw already how easy it is to implant this IOL. It's very easy, and the fact is that the patient was tremendously satisfied with the result. So with these IOLs, we have the opportunity also to treat these extreme eyes, because we know that we can revert the process. Also, with trifocal, it is an issue. This is another patient, post-LASIK cases, and he was done cataract surgery. The surgeon felt that post-LASIK it was not a good option to treat with a trifocal. Also, he has some pupillary issues, the pupil function, but it is difficult to dilate, as you can see. This is in the surgery day, but he was very, very dissatisfied. And talking with him, he wants to explant the previous IOL, but as you can see, we have some difficulty to dilate this pupil. Already 3 months post-op, but a lot of fibrosis, and it was a very difficult case. So we tried the add-on solution. And for doing that, as we cannot proceed with the dilatation, we use iris hook. Try not to push too much. One was spoken before, the implantation of the IOL, but allow us in a easy way to implant this IOL, even with poor dilatation, and give the option of trifocal quality to this patient and being satisfied with the solution. And well, I have another case, but I think we are running later, and thank you for the invitation.
Thank you very much, Filomena. Now, the last presentation, well, is somebody who would like to know exactly what would be the best technology for an EDOF lens based in all the evidence that we have. We know that Medicontur doesn't have an EDOF lens, doesn't have today an EDOF lens. So what could be? But we have different controversies. We really don't know exactly what is an EDOF or a mono EDOF, you know, and what could be the place for combining procedure, a mix and match with one in one eye and the other. But all that we know is the modification of the optics on a intraocular lens using or refractive or diffractive technology to increase the functional range of vision. This would be more or less the concept. Do we have more parameters? Yes, the ANSI tell us what need an EDOF to call an EDOF. This is, we need a monotonical decreasing of visual acuity from front from near, as you said in the red hand. And the photopic monocular with the best correction versus the control, the own monofocal of the company, need to increase 0.5 dioptries and 0.2 logmar versus the monofocal. In 0.2 logmar achieved at 66 centimeters, and we don't need to reduce in distant vision comparison with the monofocal. If the EDOF lens has all this situation, we can call this lens EDOF lens. Let's go to the publication, and we can see the FDA approval. In the left hand to the BBT, in the right hand to the Symphony. Yes, as you can see, when we compare in the BBT the monofocal of the Alcon with the BBT, you can see that in 1 to 1.5 we improve 0.5 dioptries. So more or less we can tell this is an EDOF, okay? And also we have 0.2 logmar at 66 centimeters. When we go to the Symphony, it's quite the same, but oh, surprise, we only not have only 0.5 dioptries, we have also 1 dioptrie. Is Symphony better lens than the BBT? Well, no, it has a tricky, because as you can see, the monofocal that compare the Symphony has less deep of focus, probably because it's an aspheric lens instead of an EDOF, instead of a spheric lens. So as you can see, the behavior is quite the same, and for -2 achieve both the 0.3 logmar. So achieve exactly the same. You need to see in the paper what are the defocus curve of the monofocal lens that compare the EDOF lens. All we can see of this classification is updated at September 2021, today, with all the lenses EDOF and mono EDOF that we have in Europe, with the characteristics, the action mechanism, the name, the manufacturer, also the addiction to this cutoff of 0.3 logmar, the material, and of course, sometimes the spherical aberration. We need also to see in the publication the material and method to see if the disfocus curve is with white light or green light is going to have some differences. It's very important to know. And you see the real cause of this EDOF effect. When we compare the monofocal with the monofocal EDOF, we're going to have an improvement in the middle of the profilometry in order to achieve a spherical aberration and improve this EDOF effect. This is very interesting, this slide, and is published and reported in different papers. Do we have less dysphotopsia with the diffractive AddOn lenses? Well, as you can see in this paper, the dysphotopsia, when we compare Symphony and AddOn lens with other trifocal fine vision and panoptic, apparently we don't have any differences. So probably an AddOn lens is based on diffractive profilometry is not going to reduce, at least as we read in the evidence. And sometimes we see some paper when they say, okay, we have an AddOn lens, we lose the near vision. Why not to combine, generate some kind of mini monovision, try to achieve a large deep of focus. Look at that in the paper of the left hand. They compare the Symphony with a little mini monovision on 0.5 dioptries and compare with a bifocal. The technique is 2.75. And you can see, it's very interesting, you can achieve the deep of focus of a bifocal. This is an excellent idea, excellent achieve outcomes, but what happened? No difference in dysphotopsia when we compare the AddOn lenses with a monofocal. So if you want to improve the AddOn effect with a mini monovision, the patient is going to feel more dysphotopsia like a bifocal in this paper. And you can see in this other paper, when you achieve this mini monovision of 0.5 and 1.3 with BBT, you can enlarge, but it's a shame that the author not reporting the dysphotopsia. In the study, you can see here, when we compare, for example, BBT with Symphony, this is the reported with the FDA approval. Look at the glare. When we compare BBT, we have none or mild glare with more frequency with BBT. In terms of halo, we have less moderate and severe and less staggered moderate and severe. So in conclusion, the AddOn technology in focusing for high demanding intermediate vision patients, low demanding near, and worried about dysphotopsia. The disadvantage in near vision could be reduced with mini or micro monovision, but losing the possible dysphotopsia advantages and distant vision depending on technology. And probably the best AddOn lenses for the future technology would be that one which maximizes intermediate vision without lowest dysphotopsia. So finally, I would like to appreciate that you are here with us. Thank you very much for your attention. Thank you very much for all the speakers for the four in the summary of the conclusion, and of course to Medicontur, to Laszlo, to Alessandra, to all the team, your commitment with the evidence. Thank you very much for all.